Me he enterado, sin problema.
Y empezamos. Está.
Welcome everyone. Welcome to the Early Childhood webinar. My name is Frances Gentle and I am the President of ICEVI and I'm the moderator for this webinar. UNESCO identifies early childhood as the first and most critical stage of lifelong learning and development. In this webinar, we will present professional and parent perspectives on early childhood care and education for young children with visual impairment. Our first speaker is Dr. Linda Lawrence. Linda is an ophthalmologist specializing in pediatric interventions for infants and toddlers with visual impairment. Linda is based in Kansas, USA. So welcome, Linda. She has worked with the WHO International Consensus Scientific Committee, helping to develop the international low vision rehabilitation standards. Linda will present on ophthalmological perspectives on why infants need glasses, recent treatments for retinopathy of prematurity and Leber's congenital amaurosis, and trials for other retinal dystrophies. Our second speaker is Dr. Mindy Ely, who is an assistant professor, low vision blindness programs in the Illinois State University, America. So welcome, Mindy. Mindy is the doctor of philosophy and special education, early childhood education. Her research interests include investigation of improved outcomes for children with cerebral palsy, cerebral visual impairment. Mindy will present the results of her single case USA study of a service delivery approach that prioritizes family involvement and decision-making. Our third speaker is Miss Emily Shepherd, who is Director of UsherKids Australia Limited. Emily is an Australian parent of a young child with Usher syndrome, a condition characterized by deafness and deteriorating vision impairment caused by retinitis pigmentosa. Emily will provide a parent's perspective on Usher syndrome. So we welcome Emily. Our next speaker will be Dr. Naomi Dale. Naomi is a consultant clinical psychologist in the Developmental Vision Clinic at the Great Ormond Street Hospital in London, UK. And she is also an associate professor at the University College London Institute of Child Health. Naomi will explore the design of the Developmental Journal for babies and young children with visual impairment and the results of the scientific evaluation of early intervention, including the DJVI, which she has led as principal investigator. And our final speaker for the session is Ms. Ángeles Lafuente de Frutos, known as Maria. And Maria is a teacher in the Unit of Education Attention at ONTE in the area of training, employment and Braille since 1983. Welcome, Maria. She will present on the frame of reference used by ONTE, the principles of organization and functions to prevent, plan, channel, and respond effectively to the needs of children aged 0 to 6 years and their families. So I hope you enjoy our presentations from these 5 very well-known and distinguished speakers. We will now commence the presentations. Thank you.
Hi, thank you for having me speak with you all today. I'll be talking about ocular conditions and low vision blindness, what's new. We're going to basically talk about some new testing and treatments that we're seeing nationally and internationally in the world for inherited diseases, retinal diseases, optic nerve diseases in children as well as adults. There's a lot of information on the slides, so don't try and read it all. I'll explain some of it, and then you can use this PowerPoint for a reference later on. In regards to the back of the eye, we're going to talk about optical coherent tomography, or OCT. We'll talk about the genetic treatments for labor congenital amaurosis, treatments for retinopathy of prematurity and its relationship to CVI. In the front of the eye, corneal cross-linking for keratoconus, refractive surgery for children, and glasses for infants. Now, when I look in the back of the eye, this is what I see. This is the optic nerve, this yellowish area. Now, that is brain tissue. We can directly see the brain by looking inside of the eye. The center part here is called the macula. The center of that is the fovea. That's where you get your central 20/20 most clear vision from. Now, the light comes into the front of the eye, is focused by the cornea and the lens, goes back into the retina, where it's processed and made into electrical energy to go down the optic nerve into the brain, where the information is processed and we see in the brain. Optical coherent tomography is a relatively new type of testing that uses sound waves to actually take an image of the eye. It's starting to be used in the front of the eye also, but more often the applications in the back of the eye. We can look at the optic nerve and retina. Challenges in kids, there's no official normative data. It's also technically difficult in kids who might have nystagmus, fixation difficulty, or inattention. Now, there are handheld models for babies, but these are expensive and more commonly used in a research setting. So basically, this instrument was built for adults, and we're trying to adapt it to children. We can use it to look at the optic nerve. Here's again a picture of the optic nerve that goes directly back to the brain. We can look for swelling in the brain by looking at the optic nerve. We can look at optic atrophy or death of the optic nerve cells. We can look at swelling from increased intracranial pressure, like in children with hydrocephalus. We can look at the effect of an optic nerve glioma in a child with neurofibromatosis. As far as the retina, we can actually image all of the central part here. Here's the macula again in the fovea, where we get our 20/20 vision. We can look for things like foveal hypoplasia. It's not formed like an ocular albinism, and in some cases of retinopathy of prematurity. We can look for retinal dystrophies that cause low vision and blindness that are progressive. We can look for toxicity from drugs we use for seizures in children like vigabatrin, and we can monitor tumors. We can actually also look at the brain by looking at the OCT, because remember that optic nerve connects directly, it is brain tissue. So things that go on in the brain, we can actually look at changes in the retinal tissue. In this case of a child with a craniopharyngioma, which is a midline brain tumor that affects the pituitary, causes a bitemporal hemianopia, loss of vision on both sides, temporal sides. He has good central vision, but we were able to pick this up not only with the visual field exam, which shows this dark spot on either eye, right and left, where the hemianopia is, but also this is a printout of that OCT, and we can see loss of the nasal ganglion cells that corresponds to that visual field loss. So it may be useful in following even brain tumors. Let's move on to labor congenital amaurosis, which is the most common inherited blindness in children. Now, 5% of all retinal dystrophies have labor congenital amaurosis, and the most frequent has the RPE65 genetic abnormality. This is the one that's actually now being able to be treated by placing the genetic material in a virus that's injected into the subretinal space, bringing the genetic material that the eye needs to properly function. This has been approved by the FDA in the United States in 2017. This is new technology. It's being looked at through studies also for retinitis pigmentosa. We don't have a successful long-term information or benefit after 12 months as we had hoped for, but it's research that's ongoing. Now, in infants born premature, all over the world now with better medical care, better pediatric care, better neonatal care, we're having an increased survival rate of children who are born very premature and children also born with other serious medical conditions that are surviving and thriving. So most countries now have really good screening criteria for retinopathy of prematurity. Now, to put this in context, there's visual function and functional vision. And even if we properly identify and treat retinopathy of prematurity, we have to remember that the babies that this occurs in are very small, at-risk babies for other reasons for visual impairment. In the ET-ROP study, 14% of those children who had good structural outcome, in other words, their retinas looked good after treatment, they still had visual impairment. Why? Many have CVI, cerebral, cortical, neurological, or brain-based visual impairment, depending on which name you prefer. In this condition, the ocular impairment does not explain the visual impairment because the visual impairment is in the back part of the brain. We define CVI as ocular impairment, not explain the visual impairment. More than likely, it's dysfunction, an anomaly, or injury to the retrogenicular pathways, which are essentially in the back part of the brain. Additional risk factors for infants born premature for brain damage include these common things: hypoglycemia, perinatal asphyxia or lack of oxygen at the time of birth, hemorrhages in the brain, very common in premature infants, exposure to drugs, toxins, infection, very, very low birth weight, high bilirubin, syndromes, genetic disorders, and seizure disorders. Now, CVI happens all over the world. This is not just a condition found in the developed world. On the left, the pie chart shows that 26% of newly diagnosed low vision and blindness in children at the snapshot at Aravind Eye Hospital in Madurai, South India, was from brain-based visual impairment, which correlates to what we see in the United States. So I encourage you to keep your statistics because this helps you develop products and educational strategies for these children. We need to be sure we're looking at visual developmental milestones in children born premature. This is a documented screen in a peer review that looked at visual developmental milestones of children with congenital Zika syndrome compared with healthy control. And this is where we found that a significant number of our babies with congenital Zika had CVI. The poster on the right is another way to educate parents and in places where they might go that shows what a child should be doing typically at various stages in their life so that the parent understands that their child may need to see an eye care provider or at least a pediatrician to see why the child's not responding in a typical manner. We use a variety of testing tools to measure vision, visual function, and the child that are readily available. So back to retinopathy of prematurity, there's different treatments that are available. This one is laser photocoagulation. The lasers are available all over the world. This doctor is looking inside of the eye at the child through an indirect ophthalmoscope. Here on the right, we can see these abnormal blood vessels. You can see this red here. And down here, the white spots are actually the laser marks, which are the way we destroy the sick retina. This causes the regression or going away of the new blood vessels because it gets rid of the things that are causing new blood vessels, which is VEGF. VEGF is secreted by the retina. It's a growth factor to make new blood vessels develop, but in the eye, they're bad. Okay, that's what you have to remember. VEGF in the eye is not good. So the other way we can treat this is by injecting substances that cause the VEGF to go away. So we can use laser with general anesthesia, or we can use anti-VEGF injection into the baby's eye. You can see a picture down here of the injection. This only requires sedation. So in some circumstances, it's much safer to use the anti-VEGF than to do the laser. Now, depending on the ear and the doctor, these may be used both in conjunction. There's a lot of clinical trials. There's still a lot of research trying to decide the best doses, the best timing, and whether to use a combination of the treatments. But even if the child's treated with ROP, we have to remember there's long-term sequelae. There's refractive problems, nearsightedness, anisotropia, restriction of visual field that can be from the scarring of the retina, like in this case in the lower right, where you can see the laser scars. We can have in the upper right dragging distortion of the retina tissue. And down in the lower right, we see the lack of normal foveal development in a child with regressed and treated ROP. So the child still doesn't have typical vision, even though the anatomy looks good. So we still need to follow these children who have had ROP or extremely low birth weight children. They can develop strabismus, as this shows. Severe ROP up to 40% may have eye turning in or out, up or down, and high myopia can develop in over 60% of the children with significant retinopathy of prematurity. So these children need long-term follow-up for life. Now, in the front part of the eye, we have refractive surgery, now corneal cross-linking, and of course, glasses. Pediatric refractive surgery, as you can imagine, has narrow indication. There's a lot of ethical questions, and it's for children unable to wear glasses or contacts because of facial structure or special needs. This may include a lens implant inside of the eye without taking out the original lens, or it may include laser procedures such as LASIK or PRK. Keratoconus, another blinding eye disease. Now we have corneal cross-linking that can actually stabilize this condition. It's a combination of a vitamin B drop with ultraviolet light. It does require general anesthesia in children. It does not cure the condition, but it will stabilize. Now, infant glasses are something we can do now. This can help correct strabismus, anisotropia, prevent amblyopia, help in low vision, and in children with poor accommodation. Other uses for glasses in children with low vision include magnification, protection from injury, transition lenses or tints for photophobia, and poor accommodation, as I mentioned, in children with Down syndrome, cerebral palsy, or cortical visual impairment. This must be individualized. On the top, you can see a well-fitting pair of lenses on this little girl. In the middle, this little girl has glasses that are smashing her eyes shut. Of course, she's not going to want to wear those. And the little boy here, initially, the earpiece was coming around, wrapped around his ear, and very uncomfortable. Once that was fixed, he tolerated his glasses much better. There's a book online you're welcome to download and share with your families in English or Spanish that further describes the use of eyeglasses in the birth to 3-year-old population. We need to understand why the glasses are needed, and the educational team and family need to understand when the glasses are to be worn, what the expected outcomes are, how they may promote visual, social, motor, and communication skills. We need to be able to assess the outcome and understand the family quality of life issues for another device. So thank you very much for your attention. I want to briefly mention that we are doing Tele-Ophthalmology and Rehabilitation. There's some things we can do: alignment, visual field scanning. We can see the child in his functional and natural environment, which is very helpful, but we can't yet do a medical examination online. So thank you very much for your attention.
Hi, my name is Mindy Ely. I'm from Illinois State University, and I'm going to talk to you about increasing parent-professional collaborations during home visits with infants and toddlers. So first of all, I served as an early interventionist with infants and toddlers with visual impairments, and I just had a really difficult time getting parents involved. They wanted to, they saw me as the professional. At that time, I probably saw myself as the professional, and they wanted to go in the other room while I worked with their child. But that's not collaboration. And we know that collaboration and parent participation is really important in early intervention. In fact, the literature shows us that parent involvement increases follow through, it increases confidence and competence in parents. Child outcomes are better, parent-child bonds are built, child engagement throughout the routine, the family routines are increased. So we want parents involved. We actually did a very involved, a very elaborate literature review that's published in Journal of Visual Impairment and Blindness. And you can see it under Ely and Ostrowski 2018. But the reason for this review was just to look. So these things that we say in early childhood that are important and foundational, does that hold true in the vision field, in the vision literature? And so this manuscript that I have here on the screen that was published in 2018 really looks at those foundational concepts and looks for alignment and to see if we in the field of visual impairments really do value those same things that are valued in the field of early childhood. And in fact, we do. So there is reason to think that we should be following those best practices. So fast forward several years, I found myself at Illinois State University, and I was training teachers of the visually impaired who were wanting to add a credentials in early intervention so that they could work with infants and toddlers with visual impairments. I knew that one of my biggest challenges was going to be shifting their practice model from one that was teacher-driven, expert, to one that was family-centered, one that partnered with families and really listened to the input of parents. So my biggest hurdle was getting them to think differently about their role. So what I did was I developed what eventually became known as the matrix approach. So my teachers of the visually impaired, when they were learning early intervention, I was going to send them into a home to do a home visit, and they wanted a lesson plan. They wanted to pre-think, what's the plan? How am I going to engage that child? And how am I going to assess progress? Or what reflection am I going to do about that child's learning? That's very teacher driven. What I wanted them to do was those same things, but I wanted them to engage parents. In essence, I wanted them to coach the parents to plan, find their child's needs, engage, find activities to actually help their child meet those needs, and then reflect on whether it worked or whether it didn't and make a new plan as necessary. So that coaching is what I wanted to teach my teachers to do. So when I created that phase approach, and then I had university students that I could try it with. So I did some trials, and eventually we came what turned out what would be the final iteration. I published in Journal of Visual Impairment and Blindness, I published a recap of the approach with a couple of students. So you can find that at Ely, Guilford, and Hollinshead 2017 in Journal of Visual Impairment and Blindness. And they found some things that really worked that helped them with the approach, and things that they didn't use as much with the approach. And then we also published the final iteration on the website eiviprofessionals.com. That stands for Early Intervention Visual Impairment Professionals.com. That was made it available so that people could access it, broader than our own university students. Then in the meantime, I started my doctoral work at University of Illinois. And in that work, we decided to go further with the matrix approach to really study its efficacy with professionals. And so we started off with a survey of professionals' needs. And that work is published in Ely and Ostrowski 2017. But the bottom line to that is we found that professionals, teachers of the visually impaired that were working in early intervention, did not feel well prepared to work with these young children. And we also found that they often use online platforms to meet their professional development needs because that was what was available to them. So given that information, let me tell you a little bit about the approach, and then I'll talk to you about what we did with the studies. So the matrix approach has 3 steps or 3 phases, and I won't go into each one of these in details. You can go on the website and the EIVI professionals website and get more information, but just a brief overview. There's planning, and that's where you sit down with the parent and you ask them, what are your goals? What do you want to happen today or within the next week? So baby steps, little goals. That parents often give you big goals, but helping them narrow that down into something that they can do right now. And then problem solving solutions, and then setting it up, and then actually practicing. So this is the engagement piece, is the actual practicing. And this, we want the parents to practice. And we as the professionals, our job is to coach the parents, not to work with the child, but to coach the parents. So we can affirm what the parents are doing. We can suggest other things. We can highlight development, give the parents some developmental information, telling them what's coming next, what else they can expect. So that is a learning time, but it's hands-on learning for the parent. And then finally, the reflection step is where we go back to the worksheet and say, okay, what did we do that worked? What didn't work? How can we extend these skills to other routines, other people? Maybe you need to train the grandma or the grandpa to do this so that they can follow through. So that's the matrix approach in a nutshell, in short, but you can go online to get the details of that. Okay, so once we had a developed approach, we had assessed the needs of professionals and established that they would benefit and would be interested in this, then we developed a single case, multiple probe study to really look at the efficacy of the matrix approach. And what we assumed, what we hypothesized was, if we were able to train professionals to use this approach with fidelity, we should see improvement in parent involvement during sessions. And so that was the reason for the single case study and our assumptions going in. And just for time reasons, I'm not giving you all the details of the study. I'm going to briefly go through the design, but spend most of my time on the outcomes. When we designed the study, we designed it so that we could capture social validity data. And so there was pre and post qualitative, it was semi-structured interviews, got some qualitative data. That is in press, but will be eventually published under Ely, Ostrowski, and Barton. And then we also had the single case data, and that is in press, but it will be published under Ely and Ostrowski. So, as I said, we had a single case multiple probe design. So we had a baseline in which they were recording their weekly session. I was coding that recording for use of the matrix approach. So I took the approach and I came up with 9 steps, and I was coding whether they were using those 9 steps. And then there's the intervention piece, and that is where they had been trained on the approach, and so then they were using it again by recording their sessions, and I was coding them. And then there's maintenance. So as I want to tell you in detail how we did the intervention. They actually took a couple of weeks to go through online training. I had created 5 20 to 30 minute modules to train them on how to use the approach. And then I met with them just to make sure that they felt comfortable with it. And then they continued on with their online or with their weekly sessions. They recorded those sessions and I coded them. But then I met with them in between sessions. I met with them to coach them. So I was only meeting with the professional and I was coaching the professional on their use of the matrix approach. So here's the outcomes. There were 4 participants, and the first participant, there was not using the approach in baseline, a couple weeks to actually go through the online modules, and then you get into intervention. And intervention, she's going and doing her weekly sessions, but in between sessions, she's meeting with me for coaching. And you see a dip in that data. That's because the parent had a baby, so she was not very involved for a little bit because she was having a baby. And then, but as you look at participant 1, participant 2, they really have nice, aside from the babies being born, they had nice fidelity in their use of the approach, suggesting that the online training and the coaching were effective in helping them to use the approach. Chris, the third participant, again, had nice fidelity, aside from the very first session when she forgot the worksheet, and the worksheet apparently was very helpful in helping her to reach fidelity. And then the fourth participant, again, had some nice fidelity. She only has 3 data points because she had to leave the study for health reasons. Her child was sick. So then social validity, we were looking at social validity of the goals, the study procedures, and the study outcomes. We found that the goals, parents and professionals in the survey, they, as we expected, parents saw themselves as learners and observers. Professionals saw themselves as experts and information givers. And that aligns with why we did the study to begin with. Then we looked at procedures, and procedures, the parents felt that the structure was helpful. The structure using the matrix approach was helpful to their learning and their collaboration in the sessions. The professionals felt that the coaching was essential for them to be able to use the matrix approach. And then the outcomes, they showed personal and professional growth. And I'm actually going to show you the components of this because I think they're very telling. So the professionals felt that they had a deeper understanding of family-centered practices, that they saw growth in the parents' confidence, that there were increases in parent follow-through, and they said that they would use the approach with other families on their caseload after the study. The parents felt that they had a deeper understanding of how to help their own child. They felt more in control of the sessions. They saw themselves as practicing strategies more throughout the week than they had prior to the study. And they suggested that they wanted their interventionists to continue to use the approach after the study was over. So outcomes, what are we getting from that? Well, online training appears to be effective, and that's really good for our population considering the geographic spread of teachers of the visually impaired. Also, online coaching, even with unfamiliar partners, appears to be effective. That's an important piece, again, because of the geographic spread. Coaching somebody that you don't know is a real possibility. And the matrix approach shows promise as a vehicle to change that thought of the role as expert and partner. We want that partnership or collaboration, and that it seems to do that. Fourth, the participants in the study saw value in the matrix approach, the structure of it. And finally, professionals and parents expressed growth in knowledge and in skills, and given the use of the approach. So there is a lot of promise. There's much more research needed. This was a small study. It would be considered a pilot. The data was variable and there were some limitations. So, but we continue to use this, and we look forward to finding additional ways to expand on this concept.
Hello, welcome. Thank you for joining me. My name is Emily Shepherd and I am joining you here from Melbourne, Australia. I am the co-founder and director of UsherKids Australia, a charity organisation that supports families of children with Usher syndrome. And I am also the parent of two incredible children, one of which is an 11-year-old boy, Lewis, who really is the reason I am here today. It truly is a great pleasure and privilege to be speaking with you, and I would like to thank the summit organisers for their incredible hard work in putting this program together. On the screen is a photograph of my son, Lewis, at age 8. He is sitting in the park with his arm around his friend Harry, who also has Usher syndrome. They are both wearing blue glasses and laughing. My presentation today will be in 3 parts. Firstly, I would like to talk a little bit about the past and how I became involved in the blind and deafblind communities. And then I'll talk about the present, where my family is at and where UsherKids Australia is at. And then finally, I'd like to talk about the future and what I hope for my own Usher child, as well as for all of the children with Usher syndrome, not just here in Australia, but across the world in our growing Usher community. This slide shows a photograph of my family. I am sitting on the ground holding Lewis, and my husband Dave is sitting next to me, holding our daughter Frankie. Lewis is about 16 months in this photo and Frankie is 3. Lewis was diagnosed with a profound hearing loss when he was 8 weeks old. It came as quite a shock and we fell in a heap. He was fitted with hearing aids shortly after, and my husband and I were thrown into a new world of early intervention, therapy, doctor's appointments, and trying to keep equipment on a wriggly baby. We found comfort in the support we received from other families we met through early intervention. Even though this wasn't what we had dreamed our life would be for our baby, we found our way knowing we were not alone. Lewis received bilateral cochlear implants at around 12 months of age, and with hours and hours of speech therapy, he began to recognise sounds and started talking. Although we were thrilled with his communication progress, we had some significant concerns about his gross motor development. He had a persistent head lag, he struggled to sit up and was very late to crawl and walk. He just seemed so frustrated with his body. We started investigating the cause of his deafness to see if we could better understand the reasons for his delays, and so began a diagnostic odyssey. 3.5 years of various doctor's appointments, scans, blood tests, before we were given the diagnosis of Usher syndrome through a genetic test. It was a bittersweet day for my husband and I. We finally had a name for what we were up against after years of searching. But knowing that this disease would one day rob our son of his eyesight was something we just couldn't comprehend. Again, we fell in a heap. We were given facts, just facts: profoundly deaf, vestibular dysfunction, vision deterioration, blind in the first decade of life, huge unemployment statistics, horrible facts, confronting facts for a family with no experience in this area. And there was no one telling us what an Usher life could be like, and all of the positive stories of people living and thriving with Usher syndrome. Again, we were alone. And so a new search began, a search for other families, other parents who understood what we were going through, and other doctors who could tell us how or why or when. But without a support group in Australia, we had no way of connecting with the right people. Our eye doctor told us that 3.5 was quite young for a child to be diagnosed with Usher syndrome, as most were not diagnosed until their early or late teens when the retinitis pigmentosa progressed. So here we are with our little boy, who at the time had great vision, and no service provider wanted to know us or could support us, because why would you support a child with good vision? Come back when his vision deteriorates was the message, and this was really frustrating as a parent. I thought surely there is something that I could be doing with my son now to help him cope with the challenges that lie ahead. And this question became my driving force. I found another family living close by who had that same driving force and wanted to improve the support for families like ours. And we travelled to an international conference, and we really came back inspired to make some changes back here in Australia. And in 2015, UsherKids Australia was established. So what exactly is Usher syndrome? Well, Usher syndrome is an autosomal recessive condition characterized by congenital hearing loss or deafness, in some cases vestibular dysfunction, and degenerative eye condition called retinitis pigmentosa or RP. The impact of these losses is compounding, meaning it is not simply the sum of 2 or 3 separate sensory losses, but instead a complex multisensory impairment with great variability between patients. Autosomal, meaning the genetic mutation responsible for Usher syndrome, is found on one of the first 22 pairs of chromosomes, called the autosomes. And the recessive inheritance means mum and dad are both carriers of a genetic condition, or genetic mutation, and don't display any symptoms of Usher syndrome. And each child would have a 1 in 4 chance of being born with the 2 mutations and therefore displaying symptoms of Usher syndrome. There are about 15 genes of our 22,000 genes in the human body that are known to be associated with Usher syndrome. And in this image, it shows 23 pairs of human chromosomes under a microscope, as well as a colour-coded illustration of the inheritance pattern in a family with both mum and dad carriers of a genetic mutation. Retinitis pigmentosa, or RP, is the eye condition associated with Usher syndrome. And it is a retinal disease where the light sensing part of the eye, the retina, is affected. The photoreceptor cells, also called the rods and cones, slowly lose function, causing a loss in visual field. And the first symptoms are problems seeing at night or in poorly lit areas, and a gradual loss of the peripheral vision or tunnel vision. And this illustration on the slide shows an eye, the retina, and a microscopic view of the photoreceptor cells which are affected with RP. This slide shows a more recent photograph of Lewis and I. We are standing side by side smiling. Lewis is wearing his glasses and holding his mobility cane. I have my arm around Lewis, and the text next to the photo states UsherKids Australia mission, which is enhancing the lives of children with Usher syndrome in Australia through information, collaboration, and connection. And our 3 founding pillars, which are to identify, educate, and support. Our original mission at UsherKids Australia was to bring together families of children with Usher syndrome. And to do this, we needed to let people know we existed. We knew there must be more people in Australia with Usher syndrome. So we set about raising awareness through various fundraising and media opportunities. And in our first couple of years, we had an enormous response and were able to begin to connect with families from across the country. It was amazing to learn about the different pathway that each had taken to getting their Usher diagnosis. And what became apparent to us very early on was that there was absolutely no consistency in Australia with how kids received their diagnosis, whether they had genetic confirmation of their Usher syndrome, and if so, who funded it, how they were being looked after clinically, what supports they received in school, what information was provided them after the diagnosis, and also what support services that each family had available to them to help meet their needs of their children. We know that in the past, children were not diagnosed with Usher syndrome until their retinitis pigmentosa started affecting their night and peripheral vision loss. And they were then referred to an eye test to confirm the diagnosis. And it's really only in the last few years, with the improvements in genetic testing, it has meant that our kids are being diagnosed well before the onset of their RP. Children as young as 1 and 2 are now receiving this genetic confirmation of Usher syndrome. And this creates an enormous gap in the medical and service sector, but also creates some really great opportunities to better prepare our children and their families for the future. What strategies can we give parents to help their children prepare? And how can we help support the health and well-being of parents and children to help alleviate some of the mental health challenges in the future? We are also trying to remove the burden which is often carried by parents of children with a disability, and in particular rare conditions such as Usher syndrome. It is well documented that the mental health and well-being of parents, and particularly mothers of children with disability, are well below that of parents with typically developing children. Parents need to become experts themselves and are continually educating health professionals involved in the care of their children about the condition and how it impacts in various settings. And one of the ways we can improve these outcomes is for parents, but is to create a network of committed and informed professionals who are communicating and collaborating. We have created 15 hours of online professional development content for a range of clinicians and healthcare providers working with families with children with Usher syndrome. And we have had attendees from over 10 different countries joining us. And this really shows that there is a global demand for this specific information for deafblind children with Usher syndrome across the globe. So I encourage anyone with an interest to please check out our website for more details. And this slide shows a photograph of an ophthalmologist holding a slit lamp towards the camera, appearing to be examining an eye. And it also has our web address, UsherKidsAustralia.com, and my email address, emily@UsherKidsAustralia.com. We currently have over 45 families connected across Australia. And as this number grows and as our community grows, it means that newly diagnosed families can be put in touch with one another, living in the same area, or might share the same clinicians or service providers, or might have similar age child and be able to provide that peer-to-peer lived experience. It is our hope at UsherKids Australia that such improvements in the diagnosis of our kids is matched by a smooth transition into consistent clinical management of the condition, and that the support sector has the required knowledge and skills in providing practical assistance to families. We will continue to advocate for a change in attitudes that we first came across, such as come back when your child's vision has deteriorated, and show that there is so much that can be done for the health and well-being of our families and children through early diagnosis, early intervention, and we will keep collaborating with all of these stakeholders involved to ensure this happens. I wanted to finish today with some hopes and dreams for the future for Lewis. And when I really think about it, my dreams for Lewis are no different from my dreams for my daughter. I hope they both grow up to be happy, healthy, confident, connected, and contributing members of the community. And I hope all children with Usher syndrome in Australia and around the world have the opportunity to be all of those things too. So I hope you have found my story of interest, and I welcome any questions either through the QA session or via the email address provided. And thanks once again for joining me.
Hello, thank you very much for inviting me to this important panel. And I'm going to be talking today on what makes for effective early intervention. And I'm Naomi Dale, a clinical psychologist and neuropsychologist from Great Ormond Street Hospital and University College London. I declare my royalty payments for licensed sales of the Developmental Journal. Today, I'm going to be talking about the development of the Developmental Journal for infants and young children with visual impairment, to explain the scientific evaluation and findings, and to pull out some key messages for early intervention. The work derives from our own clinic at Great Ormond Street Hospital, the Developmental Vision Clinic, which is part of our Pediatric Neurodisability Service. It's multidisciplinary, and we engage in assessment and guidance for parents and professionals on the functional vision and developmental aspects for babies and children with visual impairment of all ages. We work closely with our pediatric ophthalmology and other colleagues, and we have an allied developmental vision research program at University College London. So why is early intervention so important? Right back in 2002, ICEVI made a global call for the importance of home-based programs of early childhood care and education for children with visual impairment. Our own clinic has established through our clinical work and also scientific work that there are developmental delays from the early months of life in those who are born without vision or very low levels of vision, with delays of up to 12 to 24 months when we've looked at the Rennell-Zinkin scales, which are designed for assessing early play and development in children with visual impairment. We've identified a very serious concern which we call developmental setback, which occurs from the second year of life when the young child may start plateauing in their developmental scores or even losing developmental skills. And this becomes a long-term concern over time. There's a high risk of developmental setback in those who have profound visual impairment with light perception at best, with up to a third being shown to be at risk of developmental setback. All areas of development are at risk. This includes cognition, language, behavior, social interaction and communication, and the parent-infant interaction. And those with profound visual impairment are at greatest risk of delays and challenges. And again, we've shown this through research, particularly by our own team, because we've particularly looked at what are the differences between having no vision or light perception or having some low levels of severe visual impairment and form vision. So detection vision is very important to measure, and one can measure it from the very first days of life. We use simple lures at standard distance, and we're able to in particular differentiate and measure small changes in detection vision across the scale. And we refer to profound visual impairment as no visual awareness or awareness of light only. In addition, we know that there's high risk of learning disability and autism in children who are born with visual impairment. In those children with eye disorders and no known brain involvement in the pediatric disorders, so there's no expectation of any brain injury, we find levels of rates of about 17 to 20% of learning disability and 17 to 20% of developmental setback, which often develops into an emerging autism spectrum disorder. In cerebral visual impairment, where the visual impairment emanates from brain disorders, and eye disorders where we know there is a known brain involvement, such as septo-optic dysplasia or Joubert syndrome, the rates of learning disability can be as high as 40% or more. So with this at-risk population, it's extremely important that early intervention is started as early as possible. And we ourselves have been given guidance to parents and babies and young children for many years. But in 2005, a governmental program in the United Kingdom called Early Support invited our team to develop the first national early intervention program for babies with visual impairment in the United Kingdom, which we were asked to call the Developmental Journal for babies and children with visual impairment, with the idea of a journal being particularly a day-to-day diary that helps you and your child as your child is progressing. And we turn to parents and to practitioners to help us in the design and development of the journal. We had focus parent groups with over 40 families, and these parents emphasized the importance for them of early developmental support. They said that we need help in knowing how to interact with our baby. We need help in helping our child to learn and reach their full potential, and we need help for our own emotional needs at the time of diagnosis. And we also worked with focus groups of specialist teachers and early years workers who are the main profession and practitioners who deliver early intervention to babies and young children with visual impairment in the United Kingdom. So the Developmental Journal was designed to cover all areas of development, social and emotional development, communication, language and meaning, play and learning, movement and mobility, and towards independent self-care, and was integrated with a developmental vision program. And we turned to science to make it as evidence-based as possible, and our clinical and developmental experiences. That it involves developmental tracking and goal setting, and it's designed to be child and parent centered with an individual program for each child, but also parent friendly. It's written for the parent, and the parent holds their copy of the materials. And the important emphasis is that there is a practitioner parent collaborative partnership who together work out goals and together track the infant's early development. And the plan is that it covers from 0 to 3 years. But in 2011, we were invited to consider undertaking a scientific evaluation. Was the Developmental Journal more effective than other early intervention programs that were also in use in the United Kingdom, which includes the Oregon Project, the Portage Project, and centre-specific programs? And the knowledge was in equipoise, which means that there had been no scientific investigations to any of those programs at the time that we started. So in 2011, and for 5 years, we undertook the Optimum Project, which is the first national longitudinal evaluation of early intervention to investigate the effectiveness of early intervention with a focus on the Developmental Journal. And we undertook a national observational cohort study, and we were generously funded by 3 national medical charities, including Fight for Sight and the Royal National Institute for Blind People and Great Ormond Street Hospital charity. Now, we first recruited 100 children, and many of those children we studied to look at the natural history, how children were developing in those early years, and we used many different measures. With our recruitment, we focused on infants with congenital disorders of the peripheral visual system. We did not include children with cerebral visual impairment, and the proportions of the globe, retina, and optic nerve disorders, which are around 25 to 30%, match a national surveillance study. So we know that we have a reasonably representative cohort sample with many individual rare disorders. And our results were published in 2019, a Dale et al. Paper in Developmental Medicine and Child Neurology. And the findings that I'm going to now take you through are 54 children were followed through from time 1 to time 3, time 1 being 8 to 15 months. And we also had 54 children who had complete practitioner sets. So those were the subsample that we could do the analyses on. 38 children had no known brain involvement in their disorder, and 16 had complex congenital eye disorders. 13 were profoundly visually impaired, 41 were severely visually impaired, and as part of their routine home-based intervention, it turned out that 32 were receiving the Developmental Journal in a structured manner, and 32 were receiving other support as part of their home-based intervention, which they were all receiving from specialist teachers. So we then followed the children through at 3 time points: baseline, 12 months later, time 2, and 12 months later again, time 3. We had independent assessors undertaking child assessments and parent questionnaires, and the practitioners kept their own records of exactly what they were undertaking, and there were specific records if they were using the Developmental Journal. But the assessors did not know what the children were receiving, and the parents and practitioners did not know that we were particularly focusing on the Developmental Journal. So what did we find? Those receiving the journal showed moderate to large effect accelerations in learning and child cognition. So on the sensory motor understanding of the Rennell-Zinkin scales, they were 5 developmental quotients ahead of those who were not receiving the developmental journal. And in expressive language, it was as high as 11 to 13 developmental quotient points, particularly for those who had no additional brain involvement, the simple eye disorders. But this didn't reach 95% confidence. Nevertheless, the findings in terms of effect size are in line with the best effects in early intervention studies of other disabilities, such as autism. And we undertook a complex statistics called linear mixed effects model that allowed us to look at every child's individual rate of learning and whether the inputs were actually increasing their effectiveness from predictions of their own trajectory. In addition, we found that those who had some form vision, which as we had anticipated was protective, were 21 developmental quotient points on average higher in their sensory motor understanding, and this was a significant difference than those who were not receiving the developmental journal, highlighting again the very protective importance of having some degree of form vision. Those receiving the journal also had significant reduction in behavior difficulties at time 3, particularly in withdrawn behavior. And those receiving the journal also had a better experience for parents, with a significant reduction in parenting stress at time 3. And that's of interest because we had already established that parenting stress was at a high level at time 1 and time 2. And there was also improvements in the perceived practitioner-parent relationship. But there was no difference between the groups in relation to intellectual disability or developmental setback at time 3. And we wonder whether that implies that the neurophysiological aspects of intellectual disability was less responsive to the environmental input of these programs. So in summary, our Optimum study in the United Kingdom showed the journal receiving it was more effective than having other support in home-based early intervention, but this was not a randomized clinical trial. And though it was clinically relevant effect sizes, they didn't all reach 95% confidence. Key elements of importance appear to be the individualized, structured developmental framework and program that is designed specifically for infants and young children with visual impairment, and the family engagement partnership with the parent that was informing and empowering parents. For future research, we have questions we'd like to look at. Can we improve outcomes for those with the more complex profiles, such as developmental setback? Which are the key delivery aspects? Where, how often, what practitioner expertise? And can this generalize to other countries, such as low, moderate income countries? So the take-home messages are that babies with vision disorders and congenital visual impairment need identifying as early as possible, a very early diagnosis if possible, so that they can be referred to quality early intervention as soon as possible and by 6 months of age. Practitioners need to be alert to the high developmental risks in this population, and those who are most at risk are those with ongoing, continuing profound visual impairment. We've shown and argue for the importance of high quality early intervention program and services for visual impairment. The program can make a difference for the child. Parents need this guidance and support, and we've shown that they can benefit from it too. And the collaborative relationship between the parent and the practitioner is vital. So I just wish to end with thanking you for your attention, and thank you to the parents, children participants, the funders, and the Developmental Vision Research Lab of the Optimum team. Thank you.
Hola, buenas tardes. Me llamo Ángeles Lafuente y trabajo como profesora del Departamento de Atención Educativa de la Dirección de Educación, Empleo y Braille de la ONCE. Hoy vamos a hablar también de la atención temprana a niñas y niños con ceguera o deficiencia visual. En España, las comunidades autónomas han desarrollado diferentes procesos de organización y gestión de recursos para la prevención, detección precoz, diagnóstico y atención a la discapacidad, trastornos del desarrollo o situaciones de riesgo en la población infantil de 0 a 6 años. En los últimos años, destaca la evolución y mejora conseguida en el modelo de intervención en atención temprana y la necesaria coordinación entre los servicios sociales, educativos y sanitarios. Se puede decir que la atención temprana está por fin reconocida y generalizada para orientar en la prevención y apoyo de los niños en situación de riesgo o con alguna discapacidad. La ONCE, desde hace muchos años, trabaja también en la detección y la intervención en atención temprana de la población infantil con ceguera o deficiencia visual, desde un enfoque preventivo y estimulador del desarrollo infantil y colaborando con las administraciones públicas de las comunidades autónomas, prestando un apoyo complementario a esta población. En esta charla analizaremos el marco de referencia en el que trabajamos en la ONCE, los principios, organización y funciones de acogida, de evaluación diagnóstica, de intervención y apoyo, seguimiento y coordinación para planificar, canalizar y responder eficazmente las necesidades de la infancia y las familias y mejorar sus condiciones de vida. Podemos decir que actualmente todos los niños con discapacidad visual o riesgo de padecerla y sus familias tienen reconocido el derecho a ser atendidos. El marco de referencia de la intervención en atención temprana de la ONCE, además de su propia normativa de la institución y la legislación educativa actual, también seguimos el libro blanco de la atención temprana del Real Patronato de Atención a Personas con Discapacidad. En dicho libro blanco se entiende por atención temprana, cito textualmente, el conjunto de intervenciones dirigidas a la población infantil de 0 a 6 años, a la familia y al entorno, que tienen por objetivo dar respuesta lo más pronto posible a las necesidades transitorias o permanentes que presentan los niños con trastornos en su desarrollo o que tienen riesgo de padecerlos. Por tanto, la intervención que realizamos desde los equipos específicos de atención educativa a la discapacidad visual y los 5 centros de recursos educativos de la ONCE va dirigida tanto al niño como a la familia para procurar salud, bienestar infantil, prevenir posibles retrasos evolutivos y minimizar en lo posible los efectos negativos de la discapacidad visual. El objeto de atención no es solo el niño en sí mismo, sino también el niño a través de sus padres o figuras de cuidado, porque es a través de ellos desde los que intentamos movilizar aquellos cambios que ayuden al niño a conseguir su desarrollo. Por tanto, la intervención en los aspectos específicos relacionados con la discapacidad visual parte de un enfoque ecosistémico, es decir, el niño y su contexto. Nuestro modelo de atención temprana está inspirado en distintos principios. Primero, la consideración del déficit visual como un factor de vulnerabilidad porque limita la percepción e interpretación de los estímulos. El modelo tiene un carácter preventivo porque una intervención adecuada y a tiempo va a mejorar los recursos del niño y la familia para afrontar las dificultades y evita intervenciones posteriores que son más difíciles y más costosas. La intervención tiene un enfoque relacional y globalizador como forma de entender al niño y favorecer su desarrollo global. Por supuesto, tiene un carácter inclusivo porque la finalidad de la intervención es facilitar los recursos para poder desenvolverse en la sociedad, potenciando la equidad, la igualdad de oportunidades, etc. Pero para todo ello se precisa una coordinación interdisciplinar entre los profesionales y las familias. Así que los objetivos de la atención temprana son fundamentalmente 2. En primer lugar, favorecer la calidad del desarrollo y el bienestar de todos los niños con discapacidad visual grave o con riesgo de padecerla. Y en segundo lugar, dar soporte a la familia y al entorno desde el mismo momento de la detección. Podemos concretar más. Favorecer los aspectos relacionados con los procesos de desarrollo, socialización e inclusión, proporcionar acompañamiento y contención emocional a las familias, que son las figuras de apego y facilitadoras del desarrollo, informándoles, asesorándoles e implicándoles en el desarrollo de sus hijos. También promover el aprovechamiento de los recursos del entorno familiar y orientar en la búsqueda de otros, favorecer la coordinación de profesionales e instituciones implicados y, por último, fomentar la investigación y el estudio sobre herramientas y recursos para la intervención. Los destinatarios del servicio de atención temprana serán la población infantil de 0 a 6 años de edad que presenten ceguera o grave déficit visual o que tengan riesgo de padecerla, así como sus familias. Es necesario que la atención se preste cuanto antes, de ahí la importancia de la detección precoz, dada la relevancia que tiene la intervención en los primeros meses de vida. Esta intervención depende de cada caso, de la edad, del nivel de desarrollo, y va desde favorecer el desarrollo del niño en el proceso de crecimiento hasta intervenir para mejorar la socialización, la escolarización o la inclusión educativa. El marco teórico de intervención que utilizamos tiene en cuenta los avances de la neurociencia, donde se destaca la importancia que tienen en el desarrollo cerebral las primeras experiencias y el establecimiento de un vínculo de apego adecuado para la construcción de la personalidad y el crecimiento emocional sano, que puede estar condicionado cuando está presente un déficit como puede ser el visual. Por tanto, es necesaria la sensibilización, la prevención y la detección temprana. En cuanto a la primera, se hace necesario promover campañas de sensibilización a toda la población y en particular a hospitales, pediatras, oftalmólogos, en general servicios de salud y educativos, con el fin de que se asuma la importancia de la intervención temprana, se detecten los casos, se deriven para que se pueda intervenir cuanto antes, etc. En cuanto a la prevención, se hace necesario prevenir las patologías oftalmológicas en niños prematuros, la intervención preventiva para conseguir un desarrollo sano del niño y de su familia y la prevención de trastornos futuros, detectando las señales de alarma que nos indican que algo no va bien. En cuanto a la detección temprana de los bebés con déficit visual, promoviendo el contacto desde los equipos específicos de atención educativa a la discapacidad visual y los centros de recursos educativos de la ONCE, con los profesionales de la salud, los hospitales, centros de atención temprana, etc. Ahora vamos a describir brevemente cómo es el proceso de atención. En primer lugar, hablamos de la recepción de casos, que es un momento muy importante porque es la primera información que se ofrece a las familias. Hay que evitar desmotivarles, preocuparles en exceso, pero tampoco hay que despertar en ellos falsas expectativas. Por eso es básico que este primer encuentro lo realice también un profesional cualificado en atención temprana, un trabajador social, un psicólogo, maestro, un gestor del equipo específico, etc. En cuanto a la acogida profesional, es una situación por la que atraviesa la familia de un niño que recibe un diagnóstico de discapacidad visual, que es compleja y por tanto requiere una actitud de escucha, de gran sensibilidad, que ofrezca perspectivas realistas y dosis adecuadas de información. En muchas ocasiones de esta primera acogida depende el vínculo que las familias establezcan con los profesionales y la relación posterior. En cuanto a la valoración de necesidades, se requiere de unos conocimientos adecuados y de un esfuerzo de coordinación entre los profesionales. Interesará el diagnóstico visual, otras posibles patologías, el desarrollo evolutivo, la incidencia de la discapacidad visual en el desarrollo, el estilo de crianza, etc. Y por último, la planificación de la intervención, o bien, si es necesaria, la desviación, la derivación a otros equipos o centros, porque una vez terminado el proceso de acogida y de valoración, se mantendrán reuniones de coordinación y toma de decisiones entre los profesionales implicados y la familia para determinar qué tipo de apoyo precisa el niño y la familia, la periodicidad y la posible atención por parte de otros profesionales, así como la coordinación que se establezca con ellos. En cuanto a la priorización de las intervenciones, la ONCE prioriza la atención de 0 a 6 años, especialmente los niños que presentan ceguera total o aquellos que tienen condiciones de especial vulnerabilidad. También es importante la atención a los niños que inician la escolarización. ¿Y en qué nos centramos en esta intervención en atención temprana? Pues en diversos aspectos relacionados con el desarrollo emocional del niño, el proceso de apego, aspectos esenciales del desarrollo en los que interfiere la discapacidad visual, como pueden ser el desarrollo psicomotor, afectivo, emocional, socialización, desarrollo sensorial y perceptivo, cognitivo, de comunicación y lenguaje, autonomía personal, etc. También intervenimos directamente con las familias para informarles, por ejemplo, sobre los problemas que pueden causar la sobreprotección, lo que repercute en la autonomía personal, en la autoestima, etc. Y en el caso en que el niño esté escolarizado, es importante el asesoramiento al centro educativo, la socialización y otros ámbitos relacionados con los aprendizajes escolares, con especial atención a los previos de la lectoescritura, tanto en tinta como en braille, con el objetivo de que se consiga la inclusión tanto en lo académico como en lo lúdico, el recreo, etc. En cuanto a la autonomía personal, hablamos de habilidades para vida diaria, orientación y movilidad y, por supuesto, el inicio del manejo de la tecnología. Además, es necesario prestar atención a las señales de alarma que van a requerir de una intervención más específica. Por ejemplo, cuando hay un rechazo por parte del niño al contacto físico, la ausencia del lenguaje, la pasividad o las estereotipias. En la 11 nos planteamos diversos programas de intervención. Por ejemplo, el programa de intervención con familias, que se centra en la prevención y el apoyo en cuanto al desarrollo evolutivo del menor, la elaboración del duelo, la aceptación del déficit y el ajuste, el asesoramiento sobre gestiones, trámites, ayudas, prestaciones, búsqueda de recursos y servicios, la posibilidad de contacto entre familias con situaciones similares, apoyar en el proceso de escolarización, realizar el seguimiento de cada caso y plantear grupos de familias, escuela de padres, seminarios, talleres, dinámicas de grupo, etc. Pero eso sí, independientemente de las tareas a trabajar, la intervención debe plantearse en un clima de contención, empatía y apoyo, teniendo en cuenta el momento delicado por el que están pasando, proporcionando respeto, sensibilidad, discreción y confidencialidad. El programa de intervención para los niños de 0 a 6 años es la intervención directa y especializada para estos niños y sus familias en los aspectos relacionados con su desarrollo. El objetivo es favorecer el vínculo, el desarrollo en todas las áreas y prevenir posibles retrasos o detenciones en dicho desarrollo. Y en cuanto a la incorporación del niño a la escuela, nos basamos en la Ley Orgánica 3/2020 de Educación, la LOMLOE, en su artículo 8, que señala que los métodos de trabajo en los ciclos de educación infantil 0 a 6 años deben estar basados en, y cito textualmente, las experiencias de aprendizaje emocionalmente positivas, las actividades y el juego, y se aplicarán en un ambiente de afecto y de confianza para potenciar la autoestima e integración social y el establecimiento de un apego seguro. La incorporación del niño a la escuela es un aspecto de gran relevancia en la atención temprana, por lo que la orientación y el acompañamiento del equipo específico se hace imprescindible. Nos centramos en la selección del centro más adecuado, en la organización del proceso de incorporación y adaptación y apoyos necesarios, todo ello en coordinación con los centros. Se proporciona información sobre discapacidad visual, ayuda en la elaboración de las adaptaciones curriculares y de material cuando es necesario, el apoyo en actividades académicas, lúdicas, de autonomía personal, el fomento de la socialización, el apoyo al maestro de aula y a la familia y la necesaria coordinación entre el centro, familias, otros centros y otros profesionales. En cuanto a la atención a los niños con pluridiscapacidad, es decir, que presentan otros trastornos graves además del déficit visual, hablamos de la valoración de estos casos y se atiende cómo la discapacidad visual puede estar condicionando el desarrollo global del niño, así como la detección en otras áreas del desarrollo en las que la discapacidad visual puede estar influyendo. En cuanto a la coordinación con otras instituciones o servicios, hablamos que en cada comunidad autónoma se valorará la conveniencia de establecer marcos de colaboración con la administración pública correspondiente y con todas aquellas instituciones con competencias en materias de atención temprana, desde el ámbito del bienestar social, de la salud, educativo, etc., para asegurar una atención de calidad a estos niños y sus familias y la correcta coordinación del conjunto de servicios y de profesionales que en cada momento intervienen. Por último, en lo relacionado con la formación de los profesionales que intervienen en la atención temprana, es necesario que reciban una formación continua y especializada para poder desarrollar bien su trabajo. Es muy importante que estos profesionales cuenten con la formación continua, por ejemplo, relacionado con el saber trabajar en equipo, la capacidad de empatía con las familias y los niños en situación de vulnerabilidad y riesgo emocional, la capacidad de observación, de reflexión sobre el bebé y su familia, flexibilidad, capacidad para ajustar las expectativas a la realidad, la capacidad de tolerancia, contención de emociones, tanto propias como la de los padres, las madres y los niños con los que se interviene. Así que el maestro, el trabajador social, psicólogo, psicopedagogo son las figuras más importantes en esta intervención, pero el trabajo en equipo será la base para formar un grupo de apoyo emocional en el que se sumen las fortalezas de todos y se construya una filosofía de trabajo compartida. Por último, el trabajo en red, los seminarios y el grupo dato. Conviene destacar el trabajo en red para contar con la colaboración de profesionales especializados en atención temprana de otros centros o de otros equipos para que cualquier profesional que atienda a algún niño en atención temprana cuente con el apoyo, el asesoramiento o la supervisión de otro profesional con más formación o con más experiencia. Además, en cada uno de los 5 centros de recursos educativos de la ONCE existe un seminario de formación permanente en atención temprana que asume tareas de valoración, de asesoramiento, investigación, producción de recursos, puesta en común de criterios de funcionamiento, análisis de casos, etc. Y para terminar, en la ONCE también contamos con el grupo DATO, Grupo Dinamizador de la Atención Temprana, que colabora en la divulgación de la necesidad de la atención temprana de los niños y niñas con ceguera o deficiencia visual. Muchas gracias.
Thank you very much, Maria. Well, we have traveled a journey. We have looked at perspectives of eye health professionals, researchers, parents, and we concluded with educators. We had a couple of questions which I wonder if our speakers could address. The first one was for Mindy, and the second was Maria. You may wish to look at that final question about fathers. Minda, Sabina Kef in the Netherlands had a couple of questions for you, which you kindly responded to in the chat. And I wondered if you wanted to elaborate at all on those.
Sure. So she had asked about the methods for the study itself, and I didn't go into the methods in detail just for time reasons. However, yes, there was inter-observer agreement throughout the study. So we followed formal methodology for single case design, and but it was a pilot study. I mean, we had 4 participants and 1 ended up having to drop out as a result of medical issues. And there were there was variability in the data. So we certainly need to do some more to verify our findings. However, we were very encouraged by the outcomes in the use of the approach. And obviously what we're really interested in is parent and child outcomes. And that was not something we could get out of the design that we used. So in the future, we would like to look at parent and child outcomes when professionals use the matrix approach as a service delivery model. Thank you for your question.
Thank you. Maria, would you, the question about fathers, and I noticed Sabina is one of our great contributors to the chat, so thank you, Sabina. You addressed that also to Emily, but unfortunately we've lost a couple of our speakers due to connections. I know I've had an email from Naomi Dale saying she had difficulty entering the link. I've resent it. Maria, do you, and I might invite Linda also to talk about this. I know you are an ophthalmologist, but that whole question around fathers and involvement of fathers. Maria, is there any particular approach that ONCE and you take to bring fathers in and the role of fathers in early intervention?
Toda la familia, la intervención que se realiza es con toda la familia, con la madre, con los padres, con los hermanos, con los abuelos. Toda la familia tiene su figura, tiene su papel. Quizá a veces cuesta por motivos varios, ¿no? el que la figura paterna acuda a las reuniones, pero cada vez se observa que cada vez está más presente, que es necesaria esa colaboración de todos, ¿no? Todos aportan.
And I agree totally with Maria. We are actually seeing more and more fathers bringing their babies to appointments because both parents are often working. So the father takes a much more important role. And I think what Maria said also about siblings, we so encourage sibling play and siblings to be involved in the early intervention program. So.
Thank you, Linda. Well, we are coming to a close of this. I think there has been general agreement amongst our speakers that early intervention is absolutely critical to minimize developmental risks and to ensure that young children with vision impairment reach developmental milestones. Our speakers have also focused on family-centered approaches and child-centered approaches, including with Linda referring even to the importance of individualizing the use of spectacles, and Mindy with her approach, the matrix. There was a question, Mindy, as to whether you are still using the matrix, if that is still continuing. And there was also a question to Naomi about the Developmental Journal and still if this is still used. The chat will be recorded and our speakers will have more time to respond to any questions and comments in the chat. And I do recommend that we look at some of these texts and journals that have been produced by our speakers, because there's definitely some valuable information in those. Thank you to everyone who has participated in this webinar, and thank you to our participants for the questions in chat. Please have a good day, and I will draw this webinar to a close, and I thank you very much.
Okay, thank you.
Adiós, gracias.